Welcome, everybody. Glad you could join us tonight. Welcome to the monthly meeting of our nonprofit plant-based nutrition organization, Wisconsin, or PBNOW. I'm your host, Terry Lynch. The mission of our nonprofit group is to educate, inspire, and support each other on an evidence-backed, whole plant food-based nutritional path for a healthier, happier life. Our group is open to everyone, those plant-based and those just curious about it. It's meant, again, to be a non-judgmental place to get information, inspiration, and support. If you'd like more information about our group, our upcoming meeting dates, speakers, and our resources, or to check out videos of our past meetings, just Google us at PBNow. As we do each time, can I see a show of hands or thumbs up icon on the bottom of your Zoom screen to show how many of you are currently following a predominantly plant-based lifestyle? See a few popping up there. That's great, thank you. As we mentioned at the beginning of each meeting, the evidence of the benefits of plant-based nutrition and improving health and quality of life for people of all ages, as published in non-biased medical research, is quite striking. Whether it's improving health through increased energy, weight loss, strengthening our immune system, preventing, slowing, stopping, or reversing problems like allergies, digestive problems, diabetes, heart disease, and early dementia, or increasing our quality of life by helping us feel better quickly, increasing endurance, athletic performance, speeding recovery from exercise, reducing joint pain, clearing thinking, or reducing the physical, emotional, and financial side effects of the illnesses, drugs, and procedures often recommended to treat the conditions plant-based nutrition may help us avoid. The research shows that our bodies do a wonderful job of healing themselves if we stop inadvertently damaging them daily with poor nutrition and start giving them the nutrition they need to heal and function optimally. It's truly remarkable. Now let me tell you what's in store for you tonight. Tonight we'll hear from the past president of the College of Lifestyle Medicine, Dr. Cate Collings, and we'll follow her presentation with Q&A. By the way, don't hesitate to pop your questions in the chat box during the presentation, and we'll try to answer as many of them as time permits at the end. Tonight's program should end by 7:30 Central Time. As a reminder, we have meetings every month, usually on the second Thursday of the month at 6 p.m. Central Time. And next month, we'll be hearing from plant-based coach Michelle Stamp. I think you'll enjoy it. We'll post more information about our upcoming meetings and speakers on our website, pbnow.org. If you register on the website or are already registered, you'll receive email reminders of our events as they approach. And last, quick technical note, during the meeting, everyone but our speaker will be muted, and we ask that you stay muted to avoid background noise and allow everyone to hear our speaker. All right, here we go. As we mentioned a few times in our prior meetings, a fast-growing medical specialty in and outside the United States is lifestyle medicine, which includes plant-based nutrition as one of its integral pillars. Many primary care physicians, as well as medical specialists, are becoming boarded in lifestyle medicine. And the primary national professional organization for physicians boarded in lifestyle medicine is the American College of Lifestyle Medicine. We are fortunate tonight to have as our featured speaker the past president of that organization. She was educated at the University of California, the University of Wisconsin, the best out of the group here, and Stanford University Medical Center. She is an Alpha Medical Honor Society member, an American Medical Association delegate, and has over 30 years of experience in cardiology. Tonight, she'll talk to us about lifestyle medicine, plant-based nutrition, and share some insights on making healthy changes easier. It's my privilege tonight to introduce to you our featured speaker, Dr. Cate Collings. Dr. Collings?
Yeah, thank you, Terry. Yeah, as Terry didn't mention that I'm also a Wisconsin person. He did mention that I was there for 10 years. I did my graduate education and medical school education before coming back to the West Coast, where I completed my Stanford training in internal medicine and then cardiology, and have since stayed here. But my husband's from Wisconsin. We have many family and friends there, and we will be heading there for a visit in just 2 weeks. So I'm glad the weather is shaping up there. So what I want to do tonight is really give you a lot of insight into the rapidly growing field of lifestyle medicine and what you need to know and how you can utilize that for your own health and well-being. There we go. So first of all, I'm going to define the field of lifestyle medicine and talk to you about the value of this as a construct, and then give you a little bit of time as to the background sciences, the sciences that underlie lifestyle, including the field of epigenetics, which I find personally to be really revealing. But then I want to sort of change course and talk with you about why knowledge is not all the power we need, and how we need to also understand the science of behavior change. I think you'll probably all agree we have no shortage of content available to us now, that which is credible and that which is not so credible. But if knowledge was all we needed, we'd probably see a better health status within the United States, and we wouldn't see the long lines at the In-N-Out Burger. I'm not sure if you guys have, or Culver's in Wisconsin. So I'm going to level set first by telling you the formal definition of lifestyle medicine, which, as Terry said, is now a board-certified field, a medical specialty that uses therapeutic interventions to not only prevent, but oftentimes treat and reverse chronic conditions, included but not limited to cardiovascular disease, the number one killer in the United States, type 2 diabetes, and obesity. And lifestyle medicine certified clinicians are trained to apply evidence-based, whole person prescriptive lifestyle change to treat and, when used intensively, often reverse such conditions. And as you'll see, whole food plant-based nutrition is one of the 6 pillars of lifestyle medicine. But along with the importance of all these other pillars, that being exercise, sleep, substance use or misuse, the really importance of positive social connection and stress management. So all of these pillars, so the American College of Lifestyle Medicine is not the American College of Plant-Based Nutrition, it is the American College of Lifestyle Medicine, because all of these pillars really are important and have a bidirectional relationship with one another in helping people and in creating better health outcomes. It's interesting. There we go. So lifestyle medicine draws from many of the sciences of medicine, and it applies to many fields of medicine. So it draws from, as I referred to, the field of epigenetics, but also the emerging science that we know about the microbiome. It draws from nutrition sciences, exercise sciences, the emerging sciences on aging, as well as psychology and behavior change. And it applies to not just primary care, internal medicine, family practice, pediatrics, and OB-GYN, but also to all the subspecialty care fields. Again, not limited to cardiology and endocrinology, but as we know more and more now, to oncology and lifestyle-related risks for oncological disorders. And it applies also to physical, mental, and social health. And we know that we need to factor in also the social determinants of health. So why is lifestyle medicine so important now? And really, it's because of the chronic disease epidemic that we have in the United States that's been under our watch for many decades. We know that 6 in 10 Americans have chronic disease. We know that 4 in 10 have 2 or more chronic conditions, that 40% of Americans will be diagnosed with cancer, half have cardiovascular disease, and 1 in 3 Americans have prediabetes. We now see a lot of prediabetes in the teen and young adult population that we never saw before. 90% of those pre-diabetic patients don't recognize that they have it. And we have 34 million people living with type 2 diabetes. And I'm sure it's not a surprise to any of you that nearly 3/4 of Americans are overweight or obese. So these are things that have a personal effect for people and their families, a burden for their families and themselves. And it also reflects unsustainable economics in that healthcare costs in the US now are over 4 trillion annually, and 80 to 90% of these costs are attributable to the treatment of chronic conditions born from or exacerbated by lifestyle. And the lifestyle medicine clinicians are particularly interested in diabetes because this is a condition which has been just exponentially increasing over our watch over the decades. And despite the enormous development of pharmaceuticals in this field, patients with diabetes have 2.6 times higher medical expenditures. We're now spending about 245 billion, and it's projected to be 7.2 trillion in just 5 years. So leaving aside the personal burden of that health for individuals, it's a huge burden on pharmaceutical and healthcare claim costs, and that lands on employers, patients, and payers, and of course us as taxpayers. So diabetes is a particularly reversible condition and one that we're particularly invested in the field of lifestyle medicine in helping to manage this epidemic. This is a report from the U.S. Burden of Disease collaborators. They come out with a report roughly every decade. This shows that diet is the #1 risk for disease and disability in the United States. Of the top 10 in this, 7 out of 10 are lifestyle related. And in a companion report that is in the global burden of disease study, we can see that a very similar impact of suboptimal diet on mortality and morbidity, just highlighting that we need to improve diet across all nations. Now, in some cases, this is different across different countries, but when they compiled this, the leading things were the high intake of sodium, the low intake of whole grains, and the low intake of fruits, and attributing to about 255 million disability-adjusted life years and 11 million deaths. So an enormous burden. So what do Americans eat now, and how do they meet the current physical activity guidelines? On the left side are the dietary patterns of effectively what America eats now. This is from the American College of Lifestyle Medicine, but really showing where we have this increased risk for diabetes, type 2 diabetes, heart disease, and in some cases, cancer. And again, reflecting that it's the leading cause of death globally. So anytime we can move anywhere along the continuum towards what your organization is about, towards a whole food plant-based eating plan, doesn't have to be a whole food plant-based pure eating plan, but anytime we can move people and help them and support them to move along that continuum, we know it will translate to decreased risk for these chronic conditions. In terms of physical activity, we know that the physical activity guidelines for Americans, this shows the 2020 data, just 5 years ago, shows that nearly 50% of Americans don't meet either the aerobic exercise guidelines or the strength training guidelines, and about a quarter of them meet both. Another quarter just meet the aerobic guidelines alone. So we're really far from the mark of where we need to be. And I'll show you some more data to show why this is also so important. So people in the US live shorter lives and spend much more on healthcare compared to peer countries. We had an improved life expectancy all the way until about 2017, and then we've lost ground since that time. So these again are similarly affluent countries. And this shows that we spend, in some cases, twice as much or more on health spending to get a lower life expectancy than in these, again, peer countries. This shows the healthy behaviors associated with health span. I'm sorry, let me go back up. Yeah, as reported in a 2023 geriatric journal. So many of us think, yes, it would be nice to live a long life, but others are very invested in improving their health span, right, over lifespan. Both is great, but health span is the ability to lead the most active and disability-free life for as long as you can is oftentimes at the top of the list. So we know that these behaviors are the ones that make this more likely, which is not smoking, limiting the alcohol. There's been a lot of information out there recently, a little bit of a change of messaging. Alcohol so often said to be improved cardiovascular health. And now the data is pushing it more the other direction, particularly as it relates to cancer. Body mass index, a normal body mass index. This shows the exercise level that predicts preservation of function to improve that health span. And then again, getting back to social network, we looked at those 6 pillars. The social network, those that were socially active, had the most people around them to socially support them, had the healthiest health span. And that was a great predictor as well. We also know that lifestyle medicine and plant-based nutrition specifically is very important in a warming globe. This is an article out of the Journal of the American Medical Association, published from Harvard, looking at this beautiful parallel between personal health and planetary health when we move things to a green, if you will, plant-based diet. Not only do we increase human lifespan, decrease these medical comorbidities, but we decrease global warming, importantly. And the opposite is true in an increasingly industrial-based, animal-based diet, where we know that lifespans are decreased, more medical comorbidities, but also contributing a large portion to global warming. And I might add that if we look at the trilogy of personal health, planetary health, and animal health and well-being, we see that all of that is translated through our choices and what we eat three times a day. So lifestyle medicine as a clinical field approaches healthcare with new solutions. If we look at the traditional healthcare paradigm, it's a management approach. Individual comes in, we now find diabetes in the individual, we now find coronary artery disease. We set upon managing. There's nothing wrong with that, but we manage with increasing tiered approach in pharmaceuticals and in procedures. And we go through that tiered approach. I've done that for years and years. But lifestyle medicine actually takes that a little bit differently. Not only are they thinking about preventing disease before it starts, but they're really looking towards a health restoration and disease restoration. And I think Terry referred to that a little bit about the healing aspects of plant-based nutrition. So that being a clinical goal rather than the usual management approach. Lifestyle medicine physicians also tend to use some very creative clinical models, using shared medical appointments, sometimes culinary medicine sessions. This is increasingly done because that's a real skill-based kind of thing. It's also important to do the shared medical appointments because it fosters peer-to-peer support. You guys are doing that within this group as well. And in lifestyle medicine clinical models, it often brings in interdisciplinary clinical team members. So there's health coaches, there's nutritionists, there's psychologists, exercise physiologists, and so forth, and often use personal wearables and more frequent touch points with patients outside the walls of the hospital or clinic. And then importantly, this has become my major focus after years of sort of subject matter expertise or knowledge-based kind of work as a clinician, is to begin to shift things to understanding and how to leverage the psychology of behavior change and behavioral economics to help patients with their lifestyle patterns. So lifestyle medicine is now recognized at the World Health Organization within their framework, and this was a 2024 publication showing that lifestyle medicine is really not alternative medicine. It is in accordance with modern science. Its effectiveness is moderate and increasing, and it's increasingly accepted by conventional healthcare providers. And I think I'll show that to you in subsequent when I show you the emerging or the rapidly emerging. It is the most rapidly emerging field of clinical medicine. Lifestyle medicine is also a core component in what we see in all healthcare organizations. We see this in payers, we see it in, insurance and payers, in hospitals. Is many of us know that the healthcare system is somewhat broken. It's not working the way we want. We're not getting the health outcomes. It's costing us a lot of money. There isn't a lot of patient satisfaction. There is a lot of attrition in the clinical workforce and a lot of clinical burnout. So the quintuple aim is designed to focus people on initiatives that get these better health outcomes, to get better patient satisfaction, lower healthcare costs, less clinician burnout, and improved health equity. And it turns out that lifestyle medicine really fits in to all of these components. We just know that we're going to get better health outcomes if we can use lifestyle, or we can use lifestyle plus other treatments. We know people feel better when they're practicing with lifestyle, receiving lifestyle prescriptions, and feel more connected. We know it can lower healthcare costs, emergency room visits, and hospital stays. We know that clinicians who practice lifestyle medicine, it restores their, I would say, joy in medicine. Quite a lot. And we know that it can improve health equity and start to close those gaps that are so important. So the field has, I want to show you a little bit about the growth of the field and how it was started and where we've come with it. So the field began in 2004 with several preventive medicine doctors. And this is important because a lot of times people want to put lifestyle medicine with preventive medicine. But here was a group of doctors led by Dr. John Kelly saying, we're not doing enough. It's not enough to prevent a disease. We now know from our experience that we can actually stop the trajectory of disease. We can, in some cases, reverse disease. And the core competencies then in lifestyle medicine were published in the Journal of American Medical Association. It became a board certified field in 2017, and interdisciplinary certification began in 2018. And then in 2022, we were invited to the White House Conference on Hunger, Nutrition, and Health. That was the first time that conference had been held in 50 years. So as a medical specialist, specialty organization, we were asked to come to the table for that. And then just recently, last year, we were inducted into the House of Delegates for the American Medical Association, and I'm a delegate there. But this is important. The incoming president of the American Medical Association is also board certified in lifestyle medicine. So this is a great opportunity to begin to spread this message as part of healthcare transformation to benefit really our health outcomes in the United States. This shows you a little bit about how lifestyle medicine education is being integrated across the continuum, anywhere from pre-college curriculum to college curriculum to academic pathways through graduate education and medical school education, and then on into residencies and fellowships. And of course, for clinicians of any type that already are certified in their field, whether they're a nutritionist, whether they're an exercise specialist, a physician, a physician assistant, whatever, there's already CME coursework for them to do to bring their knowledge up to speed. So our membership has grown enormously, and I'm just showing you what's happened since 2020, but to give you a flavor of that, I joined the organization in 2015, and we were 500 members, I think. And now we're over, this is only takes us to 2023, but we're over 13,000 members. We have more than 30 member interest groups. These are range anywhere from physicians in cardiology to endocrinology to even pharmacists, to health coaches, to nutritionists. We have more than 110 health systems and more than 350 residency programs, and lifestyle medicine interest groups are just emerging more and more at medical schools around the country. There's a lot of medical student interest in this. This shows just a few of the health systems that are partnering with the American College of Lifestyle Medicine. They have champions, or they have lifestyle medicine service lines, clinical consultation available, any number of things and they work collaboratively in our council to help one another in best practices and how to get these kinds of programs going in health systems. And then I wanted to share with you, we now have a way to find a board-certified lifestyle medicine provider so that this will be a provider that's aligned with your interest in plant-based nutrition. If you're already oriented in that direction, or you're obviously interested because you're coming to this, this is a place that you can find somebody who's potentially in practice nearby. So let's change course a little bit here and just spend a little bit of time, I'll check my time here, kind of thinking about how does lifestyle change? What is the pathophysiology of lifestyle, and how does this drive these conditions? And so if we look at the one side, we've got, diet or, exercise or sedentary lifestyle, stress, it's such an important thing, sleep, addictive behaviors or social isolation, and what drives this? This comes out of a summit held in 2020 and published from that in Frontiers of Medicine. And this was scientists that were subject matter experts in all the pillars of lifestyle medicine. This was an international group that came for this summit. And so what was agreed upon is that the underlying ways that these work is through microbiome alterations, positively or negatively, epigenetic changes, which I'll talk about a little bit more, and then also just on direct cellular stress and injury. And that the common pathway of all of these changes goes through inflammation. That's a very nonspecific term, but it's a valuable term nonetheless, and then drives these variant, conditions. We think, what does cardiovascular disease have to do with cancer? Aren't those just two different pathophysiologies? What does it have to do with depression? How are those related? Obesity, type 2 diabetes. Why are these one and the same? They're all driven by these same lifestyle alterations in these pathways. So what we find is that our DNA is not our destiny. And I have a lot of respect for what we can learn from genetics. We can learn a lot now in terms of targeting chemotherapy. We can learn a lot about risks, by looking at DNA analysis and genetic analysis for people. So there's a lot to be learned, but DNA is rarely our destiny, but our epigenetics may be. And so epigenetics is a really fascinating part of this for me, because it really is the study of how everyday lifestyle behaviors very dynamically switch on and off gene expression. That's an optimistic thing because it can say, hey, what I do today can really, and tomorrow, and maybe for the next 2 weeks, can really change the expression of something that I know I'm genetically have a propensity towards. As an example, type 2 diabetes. I can pull that lever on and off and get favorable or unfavorable outcomes. So epigenetics is everywhere. It's not just in what you eat, but it is how you interact with others, how you sleep, and how you exercise. And so it's very much just translates to lifestyle expression. Our everyday decisions translates into epigenetics in a real-time way. So this shows how, what we have in our environment or how we make our decisions changes our DNA expression through methylation of the DNA and histone modification. And then again, translates to these all different kinds of conditions that we face. Epigenetics is at work in exercise. This is an article dated in 2019, I think it's 2019, showing epigenetic modifications as outcomes of exercise interventions, and very different whether it was endurance or resistance exercise. So again, a lot of precision capacity here in saying, yeah, why do we have those physical activity guidelines for Americans that say something more than just walking, that also state we need to do strength training as well. And one of the interesting ways of understanding epigenetics is when we look at studies where genetics are controlled. And this is a study that was done at Stanford and published, I think, just in 2024, so very recent. We don't get the opportunity often to study identical twin pairs, but that's what they were able to do in this study. It was a randomized clinical trial of 22 identical twin pairs, and they were assigned to either, and they were given their meals and education as well, but a healthy plant-based diet. As you all know, not all plant-based diets are healthy just because they have the word plant-based in front of them. So a healthy plant-based diet versus a healthy omnivorous diet. And in this study, they found that indeed there was a significant protective cardiometabolic advantage in the plant-based diet compared to the healthy omnivorous diet. So a really nice study design, a carefully designed study, and that is recent and recently published. And then also a very recent publication looking at cognition or Alzheimer's disease. And this was published by the lead author, Dean Ornish. And why I share this is because it shows this rapid epigenetic change that can happen. So they studied patients with mild cognitive decline or early dementia due to Alzheimer's, and found that in as little as 20 weeks, they could show a significant improvement in cognition and function. So this is a very optimistic trial. This is a trial that has been ongoing for probably a decade. I think it's really speaks to one of the things that we all fear the most, which is to lose our ability to think clearly and potentially be a burden to our family. So if we were to just take a picture of how this looks over a lifestyle, on two sides of this, our everyday choices, bite by bite, mile by mile, day by day, year by year, just add up over the years to get very different health outcomes with the same genetic makeup. So if you're interested in learning more about epigenetics, I encourage you to go to a TEDx talk by Kent Thornburg, also a book by Judith Finlayson, You Are What Your Grandparents Ate, and then another one by Ken Pelletier, who's at the UC San Francisco, Change Your Genes, Change Your Life. These are all great explanations of epigenetics, and I will say Kent Thornburg is from Oregon Sciences Medical Center. Okay, so I'm going to shift here. We got another few minutes before I close, but if just to shift gear to ponder a little bit and think about and talk about, even when we know what we want and we read about what to do, again, I talked about before, there's no shortage of information available for us. We do have to sift through what's misinformation and what's correct information, but we read about things and we pay attention to learn to do something. Knowledge alone oftentimes doesn't result in any change, and people oftentimes just carry on. That was interesting information that they gave, but they aren't led to act in a way that is in their best interest. Why is that? This is a funny comic that I found a few years ago that kind of expresses something that we all come face to face with. And I'll give you some time to take a look at this. So it's kind of funny when these kind of spousal situations, it's kind of funny in those situations because self-autonomy is very strong, right? We all want to have control and take control of our own lives, and we should. It's a great self-defense tactic. But you've probably all been in the position of trying to tell somebody convince them to do something that you know is in their best interest and that you wish for them very, very much. And physicians are in this position quite a lot. So we know that the strongest human instinct, right, and very much in healthcare providers is to impart information. But the second strongest is to resist it, right? We go back to that self-autonomy. And Ed Deci, who was a psychologist who studied intrinsic and extrinsic motivation, this is a quote from him, said, "We shouldn't ask how to motivate others. Instead, ask how can we create the conditions within which others will motivate themselves to be healthy." And so when we think about, this brings me to the topic of coaching. And when many of us think about coaching, we think about the football coach or the basketball coach on the sideline screaming at somebody or putting people through the ropes. Or you think about coaching as, okay, I'm going to go get myself a fitness instructor, or I'm going to go through a crash course in some new diet program or something like that. But coaching is quite a different thing. It's really not a boot camp. And the International Coaching Federation defines it as partnering, right? That's not yelling at people or putting people in a boot camp. It's partnering with clients in a thought-provoking and creative process that inspires them to maximize their personal and professional potential. Of course, this can apply to professional development, leadership development. So there's, executive coaching, leadership coaching, and so forth, but there's also health coaching. And this same principle applies across the different fields of coaching. So we need to know more about the science of behavior change, and we need to honor that there is a science here. So I want to just share a few of these pieces with you today. And the first is the trans-theoretical model of change, which recognizes that people go through different processes of making a behavior change. And the first process starts with pre-contemplation. You might think of that as somebody who maybe is a smoker or regularly eats fast foods or something and steps back and says, this isn't healthy for me, but I'm really not interested in changing right now. I do know that I have enough knowledge to know this is not the best thing for me, but I'm just I'm thinking about that. And then the stages go from pre-contemplation to contemplation. They're taking a little bit more seriously. Someday I'm going to stop smoking. Someday I'm going to start making my meals at home. Then to action, where, maybe I'm going to go and see a doctor about something to help me stop smoking. Maybe I'm going to clean out my pantry and try to make 2 meals a day. So that person is in action phase. And then, of course, it's maintenance phase and so forth. And then the readiness to change model honors that you have to apply the right intervention at the right time. So if I want to talk to you about changing your diet to a plant-based diet and you're just in pre-contemplation, I may actually cause you harm because I might frustrate you and you might grab onto that self-autonomy and hold on to it even more fiercely. So the readiness to change model says that we have to apply the right intervention at the right time. So somebody who's in pre-contemplation, for instance, maybe they just need a little bit of a handout that, I'm going to stop that for a second, that informs them of the health risks. But that's it. You don't even advise a change. You're just giving them the information to begin to think about it in their own mind. So the right intervention at the right time is really important. And then more coach talk and less expert talk helps people a lot. The use of positive strength-based conversations is very useful over obstacle-based solutions. What's your problem? Why are you having this? Is not an effective way to help people to make the changes they want, but rather to leverage what are their existing strengths. How have you handled any number of other things in your life? And of course, people have. They've overcome all sorts of things and have enormous strengths. And so when you can shift the conversation to strength-based conversation over obstacle-based solutions, a lot of forward momentum can be made. And then building the sustainability supports, being there when people fall backwards is really important. And then recognizing that one person's not the same as the next. So designing individualized systems, again, this is where the partnering comes in rather than the boot camp perspective in terms of helping people make behavior change and in the coaching model. This is another way of showing the expert approach or the coach approach. Now, in a clinical setting, physicians may have to toggle between these two. The expert approach is the comfortable place for a physician. They assume ownership of the patient's health. They're the expert. They tell them what to do. They lead the process. They deliver the answers, and they try to apply some external motivation to comply. But the coach approach is a different approach. Again, taking off the expert hat and putting on the coach approach recognizes that people are the expert in their own lives. You want to help the patient take ownership of their health, help them be an active partner, guide, ask the questions, and try to uncover the intrinsic motivation within, because that's where we're going to get the stickiness for a behavior change that stays with someone. Okay, now I'm going to shift again. We have about 45 minutes into the hour. And this is just an exercise that I'm going to take you through before we go into the Q&A. So if you will, I want you to kind of sit back in your seat. Think a little bit, get out of your head if you can. I've thrown a lot of stuff at you. Told you about lifestyle medicine. I've told you about epigenetics. I've told you about behavior change theories. But I want you to now kind of take yourself out of that and take yourself into yourself a little bit more. And to do that, again, step back, sit back, take 2 or 3 deep breaths. And then, if you will, you don't have to, close your eyes. We're just going to do this for about 2 minutes. I'm going to ask you some questions. So I want you to begin to do some visioning. Okay. So the first question, if you step into the future, 1 year from now, so now you're in May of 2026. Just a real simple question. What do you want your health to look like? Try to draw a picture. What What would it look like? Would there be different lab variables? Would there be a different pattern of eating? Would there be a different pattern of moving? Try to paint a picture of that. Would there be different lab test results the next time you go to your doctor? So the second question is, why is it important to you to do that? Do you feel compelled to do that because you want to travel more? You want to live longer? You want to be able to play with your grandchildren more? Do you want to be less of a burden to family members if you're in ill health? But why is it important to you? And this is maybe going to stretch you, but I encourage you to do it. So how would you feel then a year from now? Let's just say that that happened. You got you pictured your health and it's there now. It's just where you want it. What would you feel like from that? Would you feel relieved? Would you feel more powerful? Do you think you would be more joyful? So before you open your eyes, maybe think about when you close after this, taking a piece of paper, a pencil, and if some thoughts came, percolated through, write them down and consider what maybe one step you could take to move towards that vision. Just one step. We always know that small steps are the best steps to get things moving. Okay, thank you for inviting me, Terry, and you can open your eyes, and I'm happy to take any questions.
Oh, thank you, Dr. Collings. That was very informative and practical at the same time. It's hard to put those together. Let's take a look and see at the chat and see if we've got some questions here. And don't hesitate to put questions in. Anybody who wants to ask a question. I'm good. One of the things, and I wanted to ask, as you were going through this, talking about different ways to get your health, and they're kind of the normal Western medicine approach, as opposed to lifestyle medicine. Do you, from personal experience, and do you know if there are any studies that might even back this up, as far as the expense is concerned? Is it like, do you consider lifestyle medicine less expensive than traditional medicine?
Right. There are studies, Terry. They're not large studies that yet come out of large healthcare systems, but there certainly are. One of the programs that has been implemented is something called the Complete Health Improvement Program, now called PIBIO, and they generated costs of care years ago to be able to prove that point. And so, yeah, I think that we have good data that patients who are treated under a lifestyle medicine framework can experience, better health outcomes, but also less care costs, whether it's their pharmaceutical share and decreasing pharmaceuticals, decreasing doses. We have lots of data to support that.
That's excellent. One more good reason to take steps in this direction.
Yeah.
Patrick asked, is it worth, just lost Patrick there. Is it worth the extra money to buy organic ingredients and foods over non-organic?
Right. Yeah, no, that's a great question. And it's one we all wrestle with, and probably more now than ever. I think I see a little bit bigger gap between the non-organic and organic now, for sure. So, I use the Dirty Dozen or the Clean 15. That I kind of hold that in terms of how I'm going to spend my grocery dollars and where I'm going to spend on organic or non-organic. And I don't sweat that is the largest issue in terms of how I make my dietary choices. And as many of you probably will know who have adopted a plant-based eating pattern, it's less expensive, and we do have the data for that in general. Again, it doesn't have to be fancy foods or superfoods, or things of that nature. This is basic ingredients, and it turns out that the grocery bills are cheaper, and there is data to support that.
Jennifer asked, would you please list the books and authors again?
Oh, back to that was Judith Finlayson. You Are What Your Grandparents Ate, and Ken Pelletier on your genes. What was the title on that? Yeah, I don't know what the title exactly was on that. But then the YouTube video was Kent Thornburg.
Barbara asked, is bioidentical hormones part of lifestyle medicine?
I'm probably not qualified to comment on that at all, but I would say that in general, that would not be, for instance, a pillar of lifestyle medicine within our member interest group that is with obstetrics and gynecology. I'm going to predict that is not a main topic. I think where lifestyle medicine is going a little bit more is in managing menopausal symptoms with dietary changes, and then also managing fertility with dietary and lifestyle changes.
I know there have been some studies on the menopausal side of that, I think by the Physicians Committee responsible person,
PCRM, yeah.
where many of the symptoms were the negative symptoms were much reduced.
Yeah, I think in general, yeah.
And I know that heard of people who have had PCOS who went plant-based, and on the fertility side, ended up having children when they were told that they'd never be able to have.
Yeah, that's very, very true. In fact, one of my physician colleagues in cardiology he and his wife had been, in some fertility difficulties for several years, and they both just decided to completely change their diet, and now they have 3 lovely children. So he was pretty convinced.
Now they're getting less sleep than they did before.
That's right.
Have to work on that pillar.
Yeah.
Joan says, do you see any future for changes in insurance, Medicare reimbursement for lifestyle medicine issues?
Right. So lifestyle medicine is, again, there's a lot of ways clinicians are building in, largely through the usual means of billing E&M codes, evaluation and management codes, particularly if the individual has an existing condition, right? They're coming in to see them for prediabetes. Well, they're applying lifestyle medicine interventions, and they, can bill the same code, which is to say that the patient is allowed to see that physician for that condition and receive the treatment at the clinician's judgment. But the other way that we're bringing in the interdisciplinary team so that people have access to a nutritionist, to an exercise specialist, to health coaches in that shared medical appointment model. So that the nutritionist can come in and handle some of the sessions, the exercise specialist others, the culinary medicine sessions and so forth. So yes, insurance is going along with it. We don't exactly call it a lifestyle medicine evaluation and management often. We call it an evaluation for that condition, whatever that condition is.
Cindy asks, were you saying that improved lifestyle can prevent dementia? We have, and then she says, we have control over that with a bunch of question marks. And that's been a pretty exciting
Yes.
finding.
Yeah, it is an exciting, and there's a lot of work on this now, and there's a lot of evidence. I would say, Alzheimer's there are genes on Alzheimer's, but this was important that they were able to study that. So again, that was the genetic predisposition to Alzheimer's, and they were able to show a slowing of it. Now, I think would be premature to say reversal of an existing, but they can slow. Again, they can improve those cognitive changes. Reverse, maybe not. But prevention is a lot stronger for, and the recent data is particularly exercise as a prevention for cognitive decline, and particularly strength training, interestingly enough. Yeah. So very optimistic. I mean, and again, sometimes that is more compelling to people than the worry of a cardiovascular event, the worry of having a cognitive decline. So.
And I know, I'm a huge fan of Dr. Ornish, who was the doctor who initially, I think, was the initial one to show that you could potentially slow, stop, and reverse heart disease, which was thought to be not something that you could do. He is, and this study that more recently came out on dementia with him and a bunch of other doctors,
right,
was very exciting. And I don't know if you know the Dr. Scherzai.
Yeah, the Scherzai. Yeah.
There's a very good book that I don't remember the name of, but anybody who's interested, it's Shercai, I think, for the last name.
And I think it's Dean and forgetting her name, but they're both neurologists, and they're doing some really good work out of
a lot of
USC, I think, USC. Yeah.
So that's very exciting. Let's see. Shelley asks probably a stupid question, but to get into the field of lifestyle medicine, are there years of schooling involved, like a doctor, or does it, or probably depends on what you're going into? I think it's switching.
Yeah, I think that is. It depends on what you want to do within the field, but I think I showed on the one slide, for instance, the University of Colorado has undergraduate, I think it's an undergraduate degree in lifestyle medicine. So again, that's at a undergraduate level, but then of course, at the graduate level, you fall more into somebody who's becoming a nutritionist or becoming an exercise specialist and that sort of thing. So that would be their primary degree in those things. But there are some undergraduate programs developing where they actually have a degree in lifestyle medicine.
Jen asks, are you seeing patients or clients that want to come off any obesity meds and have success off the meds when transition to the lifestyle medicine?
Yeah, so clients, yes. I am personally out of clinical care for the past 2.5 years, but I see clients now in health coaching, and yes, absolutely, with the GLP-1s, the obesity drugs, we're seeing that patients, there's a couple of risks to those medications, and there are many benefits, but the risks have to do with the suppression of appetite and the fact that people in many cases aren't actually getting the nutrients and the nourishing food because they're not driven by their appetite. They're not also obsessed with their appetite, and that's the good side of it, but it becomes even more important that with the foods they eat, that they get the nutrient dense foods that are so much more in a plant-based diet, and to get the right plant-based proteins, for instance, and to, implement the strength training exercise to mitigate some of the muscle loss that comes along with those medications. So I think there's a huge role for what we call in the field a hybrid approach, that when people are initiated on these medicines, they should also be initiated in a lifestyle medicine program of some sort, particularly at the phase that they may want to titrate down the medications and to be able to hold on to the positive effects of that and have the support they need to do that.
And they can get a hold of you through the emails in the website. You've got it posted up here.
Yeah, yep.
That's great. Sherry says, what are your thoughts about elevated lipoprotein A?
Yeah, that is getting prime time. Elevated lipoprotein A certainly is an added risk factor for the development of cardiovascular disease, and all the more reason to, if you carry that genetic, it's not something you can control in this situation, but yes, to apply the epigenetic changes that's important, even more important, because it's an added risk factor for cardiovascular disease, and it's now fortunately being tested more. I started testing that in clients or patients, I would say, probably 2.5, 3 decades ago, particularly in patients who had early heart disease, for which I didn't find other risks for their cardiovascular condition. So it's important, and it is going to, I think, increasingly be measured. And I think it's an important thing for people, particularly with a family history, because again, it does track down through a genetic line. So they are also looking at targeted pharmacological therapy. It really didn't have any pharmacological therapy. As you can imagine, I'm ambivalent about that, but I think nonetheless, it's important that that we may, have something coming forward. To date, we have not. But
and let's see, Sherry asked in that regard about a whole food plant-based diet and what your feelings are about oil.
About oil, yeah, I think oil is I think this is an important thing. I think I am probably not convinced that a no oil approach is needed in every patient or client. I think whenever we can use a whole food fat, that's the way to go. And then if we are going to use an oil, then it would be an extra virgin organic olive oil in its raw state. So when we talk about other oils, we're concerned about smoke points, high heat smoke points, and I think I steer away from the use of those. If you are an individual who has weight management issues, I think it's a great idea to really start to learn how to cook with as little or no oil as possible, just because it's the most calorically dense food. Yeah, and then, I think the data on the seed oils depends on what you read. It's been a little bit difficult, but I think, when you use something like an extra virgin olive oil in its raw state as a drizzle for something, I think there might be some health promoting effects of that.
Thank you. And then we've got Kathy, Catherine says, would a lifestyle medicine doctor be appropriate as a primary care physician?
Could be, yes. Yeah, absolutely. See, lifestyle medicine is not yet a primary specialty, so almost every physician you would see will have been boarded in family practice or internal medicine or something, and then the secondary board in lifestyle medicine. So having them as your primary care doctor means they're going to cover all the bases that any other primary care doctor, but they will be helping you through a lifestyle medicine framework, and will have the knowledge and the skills to guide you in that way as well.
Kathy has a specific question here. My friend is having his yearly physical next week. I fear that his A1C and cholesterol numbers will be higher this year. He's taking metformin and medicines for high blood pressure and cholesterol. He thinks that the medicines are correcting the problem. And I told him that it isn't, that they are just Band-Aids. How can I help him?
Right. Well, they are certainly probably correcting the number, or possibly correcting the number, but you're getting at the issue, which is, are they working at the root cause level at helping? And so this is where we know that the lifestyle, really does get at the root cause of these conditions, the elevated, hemoglobin A1C and cholesterol. And we know that the medicines sometimes can work through some of those same pathways. Again, I don't think we ever should take a totally binary or, never medication approach. But if we really look at it, if you're just treating with the pharmaceuticals, you're probably not getting the full benefit out of getting at the root cause, because it's still going to mostly be a Band-Aid, but maybe, there are some ways that it can actually help, which is hard because sometimes people want to say, well, if I can have it taken care of with this medication, why would I put any effort into changing my own behavior or my own diet, my own activity pattern, or so forth? I'd like to bring people along to realize that you want the best of everything. You want the best of both. And certainly if you can do it with lifestyle only, then you're really getting at the root cause. If you need to have some medication, but you're doing a lot of it with lifestyle, you're getting at the root cause, and you're getting a little bit of help along the way. That's okay too, right? Don't need to take that either or approach. We can take a blended approach when we need to.
And again, you're probably saving money, if that makes any difference.
Yeah.
If you're titrating on some of the medications, you're not spending money on those things. And I think hummus is a lot less expensive than steak. So
yeah, we do have the data on the medication titration downward, when people make these whole food, plant-based and other dietary interventions. And, there's good data supporting that medication comes down. Again, that should be done under the guidance of a physician, I would say, Terry, because, again, I showed that epigenetically, things can happen rather rapidly. And so people, if they really make a commitment and put into action some of these dietary changes, they need to be working with their physician if they're on existing medications, particularly diabetes medications, because it can help them so much that they get into low blood sugar episodes. So it's good to have that collaborative approach with the physician so they can, down regulate, or I should say decrease the dosage of the medication rapidly, maybe even in advance of some of the lifestyle dietary changes.
All the more reason to go to a lifestyle medicine physician
who has that experience. That's exactly right. That's exactly.
Or a cardiologist for that.
Yeah.
Or for the diabetes, something. I'm trying to think, endocrinologist.
Endocrinologist, right?
And let's see, it's, oops, a few things popped in here, so I'm trying to get back to take these in order. Is there, Cindy asked, is there muscle loss with statins?
There is not. I think that most of the studies have not been able to demonstrate an actual muscle loss. If you take an average, across people, again, we know there are differences in how people metabolize medications, but there will not a decrease. Most of the data does not show a compelling loss of muscle function, but you will find people who can will find that and be able to report that they definitely feel weaker. They may have more muscle soreness, and so forth. So again, lowest possible dose, and being able to, if you do need to be on some statin because you have some existing disease, the data still says you should be on some, but the smallest possible dose, along with making the lifestyle changes. So taking, if you can imagine, control of this, 85% of the way, but getting the benefit out of the lowest dose of something that also has some positive effects. That's if a person has existing disease. If you don't have any existing documented coronary disease, as an example, trying to take a lifestyle only approach is very possible to cholesterol management and very effective and would be the optimal course.
Let's see, Patrick and Joan both say thank you. Patrick found the Environmental Working Group's 2024 Dirty Dozen list for prime candidates for organic foods. Thank you, Patrick. Larry says, do you agree with most of what Joe and Terry Graydon advise on the People's Pharmacy on public radio? I don't know if you're familiar.
I listen to a lot and I read a lot, but honestly, I don't know that I could make any comment on that. Maybe you're going to tell me I need to go and listen to them.
Catherine says, on the issue of omega-3 and 6, is there a difference between plant-based sources, chia, flax, hemp, etc., and other sources such as cold water fish?
Right. So the conversion of the plant-based sources is not always optimal in everyone, and I think we still a little bit lack the data to know that is completely effective. I think that, again, I'm probably a person that doesn't take an all or none approach to these kinds of things. So I want myself and I want my patients or my clients to get the best of the best, right? So because we don't know for sure that the conversion of those plant-based omega-3s is the same as what we get from a cold water fish, I would probably tell people if there's a concern about that they should have fish once or twice a week. I'm sorry, once or twice in 2 weeks. If they want to be sure that they're getting that, until we get more data on that.
Okay, yeah, and I've taken a vitamin that's got just the
omega-3s.
The omega-3s in it.
Yep.
Let's see, excellent presentation. Thank you. And Grace listed the 2025 Dirty Dozen foods.
Mm-hmm.
And another thank you. So thank you very much, Dr. Collings.
Okay.
I'm going to, as a quick reminder to everybody here, our next monthly meeting will be Thursday, June 12th, 6 p.m. Central Time. Our featured speaker will be excellent plant-based coach, Michelle Stam. We'll talk about how to make plant-based nutrition doable, delicious, and fun. If you'd like to receive notice of this and other upcoming PB Now events and are not currently on our list, just Google us at PB Now, where you can subscribe and receive email notice of our upcoming events. And if you'd like to check out parts of this meeting and parts of our past meetings, go to the video library section on our website, or just go directly to YouTube, type PBNOW in the search, and you can go back and watch entire talks or skim through to parts of each presentation that may be of particular interest to you. This meeting should be up on YouTube within probably a week or so. Thank you again, Dr. Collings, so much for the time you spent, the excellent presentation, and all the time with the questions tonight. Thanks for sharing your valuable time and knowledge with us.
Thank you.